Hello, and welcome to the Innovation Institute. We're excited to host you in this informative presentation for IV nutrition therapy. In this presentation, we'll review the safety and regulatory aspects of IV nutrition and cover some of the most frequently asked questions on the topic. This session will be led by Dr. Shaitali Patel, an expert in the practice of IV nutrition, functional medicine, integrative therapies, and anti-aging wellness medicine. Dr. Patel is nationally sought after for her professional education and training in IV nutrition and assists practitioners in multiple disciplines of medicine on the best practices for treatment protocols and program development. Whether you are new to the practice of intravenous medicine or viewing this just as a refresher course, you'll want to make notes about the key points to review for your state and which items are crucial to include in your SOPs. Of course, the Innovation Institute webinars do not constitute medical or regulatory advice, so please consult professional training and your state and federal laws and guidelines before instituting this information into practice. So without further ado, I want to give it over to Dr. Shaitali Patel, who will continue the course, and we hope you enjoy the webinar today.
Thank you very much, Tara. Hello, everyone. Welcome to today's webinar series of safety and regulation. It's a very tough series. Just please understand that we could take hours going over safety protocols and the regulatory statutes that are covering and governing the United States and their individual states. So as Tara had mentioned, please make sure your Board of Pharmacy, your State Board of Medicine, Board of Nursing, all of those are taken into consideration when you are reviewing and going over regulatory kind of laws for your practice. So let's start with IV therapy safety. Last time we talked about why IV nutrient therapy was important and what we could be used for. Now we're getting into the middle of how do we administer while we're administering these therapies. What are some safety precautions that may need to kind of have a double check with everybody in the clinic, including the prescribing, either physician and PPA, the nurses that are administering the infusion, or the medical assistants assisting with the infusions. So the 8 rights of client nutrient medication administration, always, like any other medication or drug or vitamin or nutrient that you may be given in the office, make sure that we're documenting correctly and also double checking right client, the right nutrient and medication, the right dose, the right route, the right time, right documentation, right reason, and right response. These 8 rights are really crucial, keeps you guys out of trouble whenever you have audits that are conducted by different governing bodies. One of the things that if you have crossed all your dots and crossed all your T's and dotted all your I's is that you want to definitely make sure that the right client's documentation file is there with what you gave them, how much you gave them, what route of administration, the time that you administered it, and then also documenting the reason for why you had given them. So it's as easy as documenting why you had just given somebody a Myers cocktail. Whether those reasons are chronic fatigue or nutrient deficiencies, whatever those reasons were that the prescribing personnel had given them the Myers, you definitely want to also document the reason. The response is just as important. If they felt lightheaded, they got a headache, or their IV site was slightly red or raised or warm, all those things are important. You want to make sure those documentations are occurred before the patient walks out of your clinic, just so that you can go back if anything were to happen. A lot of these things will save you from litigation and lawsuits in the future. So, again, a very important safety tip is to cross over all these 8 rights of client nutrient and medication administration. Who can administer? This is a very interesting question. We've got a lot of entrepreneurs that want to get into the IV nutrient business, and you see the hydration bars, medical clinics. We have primary care physicians that are adding more services to their list. You have dermatology offices that are using it for skin rejuvenation and things of that nature. Also an adjunct with aesthetic use, such as Botox and aesthetic facials and stuff like that. Well, the person that probably could prescribe an infusion would be somebody who is licensed in their state. So that is an MD, a DO, a nurse practitioner, physician's assistant. And then, with getting into the NP and PAs, you also want to make sure you check your state laws of what is required for you to prescribe, or practice functional integrative or medicine in general. There are some collaboration agreement documents that you have to file with the state. So for example, in Georgia, I am a nurse practitioner. I do have a collaborating MD and a medical director. The state of Georgia does not allow PAs and NPs to practice on their own. So therefore, the collaborating agreement is what secures that legality with practicing the functional medicine or integrative or even medicine in general in the state. So please check with your state board to see whether your licensure is allowed to prescribe or administer. Administration is just as important as prescribing. Nurses in the state of Georgia are allowed to administer IVs under their licensure. That is their basic scope of practice. However, there is a lot of gray zone when it comes to medical assistants starting infusions or IVs. Now, that's a very controversial argument, which differs from state to state. And even though the State Board of Georgia does not strictly have it in black and white as MAs can start IVs or cannot start IVs, the general consensus from all the training platforms is that medical assistants could probably do it under the direct supervision of a licensed personnel, which is a NPPA, MD, but still not recommended. So I would say for the safety of your clients and your patients, a registered nurse is probably your choice of person to administer the infusion. There is training required. I do strongly suggest training for all staff members, including physicians and PAs and NPs, for IV nutrient therapy. It is the basic knowledge of infusion that we all practice in inpatient hospitals and other clinics. However, when you're administering products like vitamins, minerals, aminos, things of that nature, you still want to make sure that you are following compounding rules, you're following state regulatory rules, and you're also complying with state boards, whether that is the State Board of Pharmacy or the State Board of Medicine. You definitely want to comply with all of those agencies since they are going to be monitoring your progress. IV therapy safety in terms of contraindications to IV nutrient therapy. So of course, you don't want to give it to anybody that has an allergy or a severe sensitivity to a nutrient. One that comes to my mind that you definitely have to be very careful is iron infusions. The other one's a vitamin A infusion. Another example is niacin and thiamine. The niacin and thiamine definitely, those are some of those nutrients you don't want to give too high of a dose when you're doing infusions. They actually have contraindications, and it goes back to our future or our past conversation of, yes, we use IV nutrient therapy to give increased dosages to our clients. However, there are those caps that you don't want to cross, and your compounding pharmacy or pharmacist is very crucial in determining dosages and what nutrients you can't give too frequently or too high of a dose of. Iron, again, another one. A lot of people, they prefer to get those iron infusions, in an oncology setting or an inpatient setting. It is one of those infusions you want to be very, very, very cautious. Things can go south pretty quick with the client, not necessarily from an allergy or sensitivity, but it's just one of those infusions you want to kind of keep in mind if you're doing in the office. Relative most dangerous form of hypotonic solution. So you have a severe red cell fragility disorder, thalassemia enzyme disorders such as G6PD and spherocytosis and sickle cell anemia. So if your patient has any of those conditions, please use caution and safety precautions. Make sure you have protocols to cover the clinic and the administering RN of these disorders. Have a good thorough assessment and history of the client so that you guys can have a better safety protocol for these clients that are coming in that potentially could be high risk. And then, of course, patients with severe environmental illnesses. You definitely, this is one of those things where you definitely want to take into consideration when you're doing pediatrics and older adults, is that you want to start these patients on a lower dosage, increase the dosage slowly. The infusion rate starts slower in such patients. And then example is detoxification on B vitamins. B vitamins, even though people say they're water soluble, what harm can they do to you? B vitamins can cause harm if given in large amounts and too quickly. People can have a rapid detox, such as a Herxheimer reaction, and you do not want a patient going south in your clinic. If you do have a patient that's severely sensitive to environmental illnesses, and then, we had a rapid infusion of B vitamins. So again, a good thorough assessment, a good history, and then a conversation that's opened with your compounding pharmacy or pharmacist is always important. Keep that conversation open at every point, because there are so many things that we may not know as clinicians that the pharmacist can provide information of. So osmolarity, let's talk a little bit about osmolarity. So osmolarity, one of the things about osmolarity is that you want to know what you're giving your clients. The reason being is that a hypotonic solution, an isotonic solution, and a hypotonic solution all act differently in the human body. Just a little bit of background. Isotonic is the closest to human serum from an osmolarity standpoint. It's very, very similar to human blood. Hypertonic is strongly a stronger solution of electrolytes. And then hypotonic is lower than the serum solution, which is from the human body. And in comparison to the solution, it's lower in osmolarity or concentration of electrolytes or whatever is mixed in that solution, such as D5W, which could be dextrose in that point. Carrier fluid selection, very crucial, and then the osmolarity calculator. So let's talk about carrier fluid selection really quickly. Every nutrient that you come across that you want to infuse possibly in your clients have to have a correct carrier fluid. There is chemistry and biochemistry that is involved at a cellular level when you pick the right carrier fluid selection. For example, high doses of vitamin C with normal saline. When you calculate osmolarity of high dose vitamin C in normal saline, your osmolarity level, which is a concentration of that solution, is high. When you're infusing that in a client, that can cause a couple different issues. One, it's pain at the IV site. Two, it can cause phlebitis, which is, inflammation of the vein. Three, it's burning, so you're definitely going to cause scar tissue. You may not be able to use those veins in the future. So definitely collect, the better choice of fluid in that scenario would be sterile water. Now, again, sterile water cannot be infused by its own. This is, again, a segment. If there is more information needed, please check with your pharmacist or your training platforms as to how to calculate osmolarity and what kind of carrier fluid selection is good. The lower the osmolarity, the more to close or isotonic a solution is, the safer it is for infusion. When you start picking fluids with high osmolarity or too low, you have fluid shifts or chemistry shifts with patients that can cause a lot of issues. So, you're looking at reactions, you're looking at people passing out, you're looking at a sudden hypovolemic shock in some situations. And so again, very important to pick the right fluid and calculate the right osmolarity. We will be happy to go over, the pharmacist and I would be happy to go over any specific questions on osmolarity if you have any, but this webinar, we're not going to spend too much time on trying to explain to you how to calculate the osmolarity, but definitely a very crucial step when you are trying to find compounds and infuse compounds. Additional safety considerations: the IV setup, length of infusion, drip push, drug compatibility. When in doubt, call your pharmacist. Patient comorbidities. Okay, so let's see what this is. When setting up your IVs, safety precautions, make sure your needles are not, uncapped. The patient has access. Let's say they kick the tray off your table or anything of that sort. You're not putting yourself or the patient at risk. Also, when you're starting an infusion and you want to have your IV supplies in such form that they're not falling over or tipping over, even when the patient slightly jumps or jerks, that needle is not, getting into the person that's starting the infusion. So just be mindful of, where exactly you're putting those things, aseptic technique. So make sure that you have washed hands, your gloves are worn. Also, if you're uncapping and capping things, they should be done in the safety of a tray and not on anything that's rolling of a surface. The length of infusion is another one. You don't want your drip to go too fast. If it's an IV push, follow the protocols of how quickly or how slowly the push is supposed to occur. One of the most common IV pushes that we do is IV glutathione. And if it's in large amounts, you definitely want to put it in a drip. If it's about a gram, which is basically 5 mLs, if the concentration is 200 milligrams per mil, a push, you can dilute that with normal saline or D5W, and you can slowly push it. Normally a gram, depending on your pharmacy and your pharmacist advice. I know that my compounding pharmacy, innovation compounding, says anywhere between 3 to 7 minutes, depending on the patient that you have. If you have a severely sensitive patient that has a lot of allergies, people that, that are very sensitive to nutrients, and you want to go slower. If you have somebody that can handle it better, you're definitely able to go to the lower limit of the 3-minute push. So drug compatibility is another one. You want to make sure that you're giving those IV infusions that are compatible to each other. I'll give you an example on the drug compatibility. On the days that my clients are having fatty acid infusions, we don't do any infusion that has normal saline. So you ask me, Chai, what uses normal saline? Well, iron infusions are done in saline. My ozone is done in saline because of the heparin and the blood compatibility. And one other one is the poly-MVA or alpha lipoic acid is done in saline. So if I know those are the nutrients my client needs, I can't put them on a day that they're doing fatty acids. Again, you don't want to mix saline and fatty acids together. So you want to pick the infusions that are compatible with fatty acids. So what is compatible with fatty acid is an immune booster that is mixed in sterile water. So sterile water is compatible with fatty acids because it's not saline at that point. There's no sodium chloride in that carrier fluid. So just some considerations to take, when you are trying to mix therapies or trying to bring the patient in for multiple protocols. Make sure you speak to your pharmacist on what the time frame is or what the soonest is that you can mix protocols, add protocols, and combine therapies for your clients. Always, always, always call the pharmacist. I can't tell you how many times it has saved us a lot of headaches, even if it means double checking with the pharmacist to say, hey, I have a client coming in today. This is what I plan on doing. Please, please, please. Having that relationship with that compounding pharmacist is so crucial. It will save you in the long run when it comes to drug compatibility. Patient comorbidities, definitely picking the right carrier fluid or the right protocol treatment plan for a patient that has comorbidities. So like an example is the use of D5W in diabetic patients. It's not a severe contraindication using D5W in diabetic clients. However, want to use caution when you're using D5W in a diabetic, especially if your diabetic patient is on insulin. It can, in the long run, raise blood sugar indirectly, and you do not want this client taking more insulin more than they need in terms of treatments. So definitely one of the things that I would do again is make sure that you're looking at the patient's assessment, their history, their allergies, and all the other drugs that they're taking. Have an open discussion with your compounding pharmacist in terms of what carrier fluid may be a best option for you, what drug compatibilities or issues you may have with people that are on multiple medications. And then also review their history in terms of comorbidities such as diabetes, high blood pressure, cholesterol, so that you are safely administering these infusions. All right, so this is my favorite part, emergency preparedness. So over the years, I have a lot of ICU, critical care, and emergency room training. So every clinician is going to differ when it comes to emergency preparedness, depending on their history, depending on their experience, and what kind of clinic they're running. Of course, the higher risk clinics or facilities, I would say, those are hospitals, outpatient surgery centers, a lot of a hospital or a clinic that is doing a lot of procedures. Where you think things can go south pretty quickly is where you want to start looking at these emergency protocols to have in place. So establish an emergency SOP. You definitely want an employee handbook and cover everything that you need to in terms of an emergency. Post SOP and IV patient rooms. So your patients are aware of what happens and what your plan is if in case there is an emergency in the IV room. Also conduct an annual employee training on your emergency preparedness. Annual employee training if they're there with you longer, or anytime you have a new employee starting, you want to make sure that they sign off on that employee handbook. Also read over your emergency preparedness protocols, and then every year after that, they would have that training. One of the things that is important to have in the clinic when we're talking about emergency protocols is a crash cart. Now, there's a lot of different ways you can have a crash cart. Number one, don't have a protocol in the office that you physically or your staff physically cannot perform, because when it gets into a legal situation, it's going to get super complicated. So I'll give you an example. We had a clinic that bought an AED, had a crash cart. They had a situation where the patient went south. Nobody knew or could find stuff while the episode was going on, and they were taken to court. And because they had an AED, didn't have enough training on it, they had it, but things went south. There were, it was in favor of the patient, because the expectation is if you have something, or if you have a protocol or an emergency protocol in the clinic, then everybody needs to be trained on it, including the use of the AED, including how to call 911, knowing who your emergency partners are, whether that is the EMS in the area, the hospital that's local to you, and things of that sort. So if you don't know how to use it, keep it simple. Have an emergency protocol that is simple. Call 911 could be part of that protocol as well. If you're going to invest in a crash cart and an AED, make sure that the training is occurring, and that if you need to start off at every quarter because of possibly new employees joining in, new people coming on board, then you definitely want to do it quarterly as well. That is an option. So let's talk about the crash cart and the drugs. Here's some examples that we have on here. There's epi, there's dextrose, and Benadryl. These are great to have. Dextrose, great option when you have patients on high dose vitamin C. They can tend to get hypoglycemic very quickly. That is one effects of IVC. And so having that on hand is extremely important. Benadryl, in terms of a allergy/sensitivity to an infusion, works wonders. So those are some I would keep labeled and at your drawers full of, so that you have access to them. Some other ones include aspirin, nitroglycerin, dextrose 50%, which is that dextrose we talked about right here. Narcan is another one, even though we don't do pain management and stuff like that. Narcan is definitely part of most crash carts. So definitely have some Narcan on hand. Epinephrine, like I have on there, atropine, amiodarone, EpiPens, Solumedrol, adenosine, Lopressor, cardizem. Those are some examples of cardiac crash drugs. Now, when you have those drugs on your crash cart, please make sure whoever is your administrating personnel, whether that is an RN, PA, NP, or MD, they know how to go through those dosages of what to administer at what point. I strongly suggest when it comes to crash cart training to get trained with the ABLS, which is the Advanced Basic Life Support. I think that is a great addition to most training and most clinical personnel. It saves you a lot when you have somebody that's arena and they know how to use the crash cart drugs. So again, if you're going to have a crash cart, those are some examples of drugs that could be in your crash cart. And then of course, there's equipment that comes with it. Equipment could be a couple different things depending on how big you want your crash cart to be. So airway, you want all sizes of airway, oral and nasal, in case you have to set up an airway. That's one. The McGill forceps, large and small. King airway sets are an option. Laryngoscopes and endotracheal tubes. Now, this is getting pretty serious when you're trying to get intubation sets on a crash cart. However, it is a major part of the crash cart. You want to make sure, again, if you're using EMS services, then you definitely want to make sure that the EMS is handling all of that. If you have your own, then you want to make sure your personnel is ready to use all those things. In most situations, if you have a peer MD or an NP that's worked in critical care and they're very comfortable with intubating in the office, that is definitely an option for certain practices. You want a bag valve mask, both in adult and pediatric, nasal cannula, very important if you have to give oxygen right away. Definitely, you'll have things like IV start packs, normal saline, and IV tubing, and establishing an IV is also part of the emergency medical protocol. However, in this situation, if we're doing infusions and you're in an infusion clinic, most likely you will already have an IV line set up. It's just a matter of having enough fluids on board and stuff like that in case you need it. And then a monitor with a defibrillator or an AED, depending on the practice. Of course, there's more things like syringes and alcohol pads and gauze and stuff like that. So we have a list if anybody is interested to go over. It's a very comprehensive list. The list is from the ACLS Training Center. It is the 2020 updated guideline that's been published by the American Heart Association. So that is also accessible to you guys online. I would definitely incorporate the ACLS Training Center guidelines in conjunction with the American Heart Association guidelines to make sure that your emergency preparedness and your crash cart is up to date. Once you have those in order, make sure you're doing either quarterly or yearly checks. Medications can expire, equipment can expire. Sometimes the dates on there are a little bit longer, but if you're not using it consistently, nobody's really keeping an eye on it. You don't want to reach for something that's expired in case there's an emergency. So very, very crucial that somebody in the office is keeping track of the crash cart expiration dates, use dates, BUD dates, whatever that is. If it's a multi-dose vial, once you popped it open, how long is it good for? All those things that come in with medication use should be monitored. They should be signed. A document should be kept in the folder. The physician or the prescribing personnel, whoever that may be in that particular clinic, can sign off after that. But again, major points to take from the emergency preparedness is definitely training, signing, making sure that you're checking on the expirations and everything like that. And then, of course, making sure you have all the necessary medical equipment and medication on board. If you're a pediatric clinic, make sure all your BP cuffs and things of that nature, including tubing and stuff, is pediatric friendly. If it's an adult, make sure it's adult friendly. If it's a clinic that you're seeing more obese patients, make sure those cuffs and things of that nature are very compatible to the type of clients you're seeing. One of the biggest issues I've seen in multiple clinic is that you have small sized blood pressure cuffs for patients that are slightly obese, and you might not have a very accurate blood pressure reading at all. So again, make sure all your equipment is in line with who you're seeing and the population that you're seeing. If it requires both pediatric and adult, then I would make sure that you have both pediatric and adult stuff. All right, compounding standards and regulation. This is all the fun stuff. This is where thousands of questions come in during training, and everybody's trying to understand how they can mix, whether they need a hood, whether they need a sterile room. Do I need to build a pharmacy in my office? What's going on with this? So let's dive into the standards and regulations. Please understand that these could be very state specific, and please check with your local regulatory boards, including your state boards, on regulations that pertain to you. So USP definition of compounding. What exactly is compounding? It's the preparation, mixing, assembling, packaging, or labeling of a drug or device as a result of a practitioner's prescription drug order. So what does this mean, Chai? Basically, it is customized prescriptions for physicians is how I look at a compounding pharmacy. The stuff that comes from compounding pharmacies, as we had mentioned in our earlier webinar, is tailored to your clients and tailored to your line of work. You can have dosages that are in between. It doesn't have to be between. It can be 37.5. It doesn't have to be 40. It doesn't have to be 30. That's the beauty of compounding, is you can get very dose specific with anything that you need compounded. So here's a slide that's got what it's including and what it doesn't include. So it includes preparation of drugs or devices in anticipation of prescription drug orders based on routine and regularly observed prescribing patterns. So it's anticipatory compounding is what that it is. So you could use it in the future. They can mix it for you and you can bring it to your clinic. It does not include mixing, reconstructing, or similar acts that are performed in in accordance with the directions contained or approved labeling provided by the product's manufacturer and other manufacturer directions consistent with labeling. So this is basically the difference between compounding and manufacturing. They're basically, the does not include kind of goes towards more towards a manufacturing idea, and the include goes towards more customized, which is your compounding pharmacy idea. What is the standard that we follow? We follow USP standards. It was established to protect the general public by creating standards of medication quality and production process backed by science. So who must follow the USP standards? Basically, and if most people or almost everybody in the healthcare setting, which are your hospitals, your physician offices, surgical facilities, labs, compounding pharmacies, we're all held to the same standard when it comes to the USP or even compounding. Real quick, we have several standards from the compounding. These are all from the USP website, if anybody's interested to reading in depth. What basically governs our IV nutrient therapy is the specific standards that the compounding people have left for us. So basically the USP 795 refers to non-sterile compounding. The USP 797 refers to sterile compounding. This is where most of your IV injectables and stuff like that comes in. So when you start getting more in tune to hoods, no hoods, clean rooms, can I mix on a countertop? Those are the standards that dictate sterile compounding. And that's the portion that every practitioner that's interested in IV nutrient therapy should basically read. And then you have the USP 7.1, and then you have the USP 800. The 7.1 refers to sterility standards. It outlines requirement for testing sterile compounds. And then the 800 refers to handling of hazardous medication to protect the environment. So if you have specific questions to these and things like that, make sure that you are basically speaking to your pharmacist into which of these specific standards you are meeting. If you have additional questions, your compounding pharmacy or pharmacist will definitely give you more information on the USP. Again, it's a very long topic. We can dissect this, but we would be here for hours. And so please contact either your training platform or your compounding pharmacist for additional questions regarding your USP standards. All right, so this is another one. Where to mix and administer. Point of care is basically your physician's office. You have to refer to the 797 standard, which we spoke on the slide before. And then the 1.3 basically is the immediate use compounding. It's allowed to mix 3 sterile products together to be administered within 1 hour of mixing. So yes, Ms. John comes in or Mr. John comes in at 3 o'clock in the afternoon. We do not want that bag mixed at 8 in the morning. It's definitely outside that 1 hour of mixing standard that we are supposed to be following. We cannot add more than 3 sterile products. So for example, for my high dose C patients, you've got your electrolyte mix, you've got your high dose vitamin C, and you've got your sterile water. If you're trying to add anything in addition to those things, then of course you have to get together with a compounding pharmacy and see if they can do what's called a customized package for your customized compound for you. The reason that works better and in favor of all physician offices is that then they are held to the standard. They probably have the equipment, they have the sterile room, they have the hood, they have all those protective things that they need to do to go ahead and compose or make a compound that is suitable for your patients if you're mixing more than 3 sterile products. Now, before this came in, a lot of physicians were using as many products as they could in office. It was not very clear in those terms before the 797 was more enforced and established because it was considered physician use and immediate use. A lot of people go back to that, and arguments are set that no, but I'm using it in the office right away. Well, always remember that the enforcement of the USP 797 is where we're again legally held to that particular standard that we cannot mix more than 3, and we have to use it within an hour of mixing. So please contact your local, again, boards, contact your pharmacist, contact, again, your compounding pharmacist. I can't stress that enough because it will save you a lot of headache when it comes to what can I mix and what can I not mix. The compounding pharmacies are they have their ISO classified clean rooms. They also follow all other USP chapters and standards. That's the reason that that's a good idea to work with your compounding pharmacy and pharmacist so that they can compound those needs for you where you can administer into the office. So again, they are held at a higher standard, and so are we. When we start getting out of that standard, that's where people get in trouble. So please try to follow that USP 979 standard. So this is the current guidelines, just the immediate use compound. A lot of people are not very familiar with what exactly is immediate use. And like we had stated before, it is, you mix it, and of course you have an hour to get it to your patient. It's just more in detail on this slide of what those requirements are on the low risk level as well. All right, compounding pharmacies. Let's talk about compounding pharmacies. How many types of compounding pharmacies are they? There's a 503A and there's a 503B. A lot of people don't know the difference between these two, but it's very important that you establish, especially when you're opening up your accounts with compounding pharmacies and such, is to establish whether they're both either a 503A and a 503B or one or the other, which is either just a 503A or just a 503B. The 503A adheres to USP standards. It's governed primarily by the State Board of Pharmacy. It's customized sterile and non-sterile medication preparation, and it requires patient-specific prescription, meaning if you have 4 patients or 7 patients or 10 patients using ascorbic acid, then each particular patient with their specific date of birth has to have a prescription for ascorbic acid. You can't just order 10 vials of ascorbic acid and use it for your 10 patients in your facility. So this is where the prescribing knowledge comes into place. And if you have a 503A pharmacy that you're working with, then a prescription that is specific to the patient has to be written in order for you to use those compounds for that particular patient. 503B, on the other hand, it adheres to the CGMP standards. It's limited customization or product offering. It's governed and registered as an FDA outsourcing facility. Only 72 in the United States are currently registered at a 503B status, and it does not require patient-specific prescriptions. So I'll give you another example on here. So if you have a product like, let's see, what is a product that's 503B? Magnesium could be a 503B product very easily. And you can get it in bulk from the pharmacy. You do not need a patient-specific prescription. And so that's where the difference comes in. The cost also differs when you start getting patient-specific prescriptions versus the 503B. Sometimes the 503B could be slightly higher in cost just because they're producing large amounts of whatever that customized vial or ingredient that may be. So always look at both 503A, 503B, and we need to, as providers, adhere to standards of prescription, and then, be appropriate in what you're ordering for the clinic. The 503A specific rule. Okay, so for purposes of Section 503A, a valid prescription order from a compounding drug product means a valid prescription order from a licensed physician or other licensed practitioner authorized by state law to prescribe drugs. So basically, a 503A will only accept a prescription from a prescriber. If the prescriber is a NP, PA, MD, or DO, great. There are certain people that can't authorize prescriptions. For example, chiropractors. You will see a lot of chiropractic practices that are offering IV nutrient therapy. However, they by law or state licensure cannot prescribe. So most of those practices happen to have a collaborating MD or a nurse practitioner or a PA that's working hand in hand with them, because that prescribing power needs to be kind of addressed when you're starting to order prescriptions or sterile IV stuff from a 503A compounding pharmacy. It also includes a valid order or notation made by a prescriber in a patient's health record, meaning in the chart. In an inpatient setting, a valid order or notation by a physician who compounds a drug for his or her own patient, documented in that patient's health record. So not only does the prescription go to the pharmacy, a copy of that prescription is also maintained in the patient's EMR or EHR record, so that if need be to go back and see what we had done, that documentation is there. 503A compounding quality. Again, there is a lot of the pharmacies are starting to recognize, and the physicians are starting to recognize pharmacies that have the PCAT certification. The PCAT is nothing but the Pharmacy Compounding Accreditation Board. They basically come in, it's an accreditation body that comes in and gives you this accreditation so that you are in compliance of what the compounding standards are for quality and safety of whatever you're producing. So this is very important because it goes back to, hey, I have a pharmacy, who do I work with? When you're working with a pharmacy that has a PCAB accreditation, the quality of your compounding medications is far more superior and very well put together. They've covered all their, risk stuff. They've covered the industry standards for raw materials. They've covered all of that stuff for you. They try to use the least amount of preservatives or impurities. So this is why it's really important to find a compounding pharmacy that has a PCAB accreditation. It adds value to your practice. It adds value for your patients. It adds value to any basically compounded item medication wise that you're picking from that pharmacy, is of high quality versus just regular quality. This is just 503A compounding quality control continued. Again, there's always ongoing batch testing. There's always sterility testing, endotoxins. It's very important that when they make something in bulk, that they get tested. So by the time it gets to your patients, you're confirmed that you're not getting anything that's of bad quality, or that is the quality is kind of jeopardized in terms of toxicity. If there was any sort of violations during compounding, the sterile technique is broken or anything like that, you want to make sure that they've been tested before they get to you. And then initial testing, of course, they all do that. The potency is over time. So, and then it confirms the potency for the defined beyond use date of the label. So everybody has probably come across the bud date, which is the beyond use date. That is a date that a lot of people don't understand what that exactly is, but it basically is that this compound or this medication is best used before this date, meaning the potency of whatever's in the vial degrades over time. And you don't want to use something that's, lost its potency. So essentially when it goes to initial testing, and when they're testing all these batches for our clients or for the pharmacy's sake, they're kind of noticing that particular potency of whatever that is in that vial over long periods of time or periods of time. Therefore, if it says, beyond use date, 3 months or 90 days, and that the potency of that particular medication or compound degrades after 90 days, which is probably not best use. It's not good science to probably go ahead and give that to your patients. So keep in mind when you're asking questions with your compounding pharmacies, ask them what the beyond use date is for a particular product. And that again is very important when you're looking at IV injectables. Frequently asked questions. All right, what is the expiration on an IV bag or syringe after being mixed? So there are several factors that dictate this. And again, work with your compounding pharmacist to kind of guide you in these areas. But like we had discussed, the requirements for sterile compounding, the pharmacological stability of the constituents in the syringe or IV bag. The problem with the specific answer is that it cannot exclude one or the other of these factors, and many times the advice given does just that. The maximum time is defined by the level of risk of the compound carriers, but then that time may be shortened by chemical or pharmacological stability factors. What does all that mean? Basically, if you're using high risk ingredients, if they're super active, then definitely the duration is shorter. If it's a low risk item, according to the compounding pharmacy, then you could probably use it a little bit longer. But again, my my rule is if we've mixed an IV bag, if it doesn't get given to the patient in an hour, we basically dispose of it. I know that that can cost us lots of money, but then having better protocols in the office are also just as important. And again, working with your pharmacist to determine what compounds are considered high risk, medium risk, or low risk, that will also determine how long you can keep most of these items in the clinic. What is the difference between preservative-free and multi-dose vial? This is a very important difference. Preservative-free means it must be used immediately after puncture and it cannot be repunctured or stored. You run the risk of contaminating that compound when you repuncture it or store it. Bacteria could grow in the vials. You can actually cause a lot of damage to the patient if you have a preservative-free vial that you're using multiple uses. So when you have a preservative-free vial, use it immediately and try to puncture it one time, and then whatever remains has to be discarded. A multi-dose vial usually has preservatives, and it's usually an alcohol-based preservative. This is so that it minimizes any growth of bacteria or any other toxins in that particular compound. It must be discarded 28 days after first puncture or when the BUD is reached. So what does this mean? Let's say I have a vial of something today that expires in 4 days. The bud date is registered in 4 days. So today is the 9th of September. We can say that, this is the bud date is going to be the 13th. But you say, Chai, multi-dose vial, I could use this vial for 28 days. Yes, that's right. But whichever one is first, the bud date hits first, which is 13th of September. So technically this particular vial should be used before the bud date and not exactly the 28 days that you're given on a multi-dose vial. So understanding those dates is very important, especially when you're ordering from a compounding pharmacy. If you're ordering bulk amounts of vials, please ask them what their bud dates are. If they're short and they're right around the corner and you may not get enough time to use them, then you definitely want to talk to your pharmacist about that. But the difference is very clear. Is one's a preservative free and a multi-dose vial generally has preservatives. So if you're looking for a patient that's got environmental sensitivities or somebody that has cancer or has an autoimmune disorder that cannot take those preservatives, then you definitely want to use a vial that is a preservative free. Always remember, it's almost a single use immediate vial. You do not want to store or repuncture that vial after you have used it. Do I need to perform batch sterility testing on the products I compound? Not unless you intend to store them longer than above referenced BUD. So again, it goes back to the USB 797. You want to make sure that whatever you're mixing in the office is definitely in line with what you can mix. If you're trying to do more compounding and more putting together things for your protocol for your patients that is outside that 1 hour administration time, then you want to definitely talk to your pharmacist about going and reading over requirements such as the USB Chapter 71 on sterility testing. Work closely with your pharmacist because they will be able to guide you on the risk level and what you're compounding in your office. And most of the times they're able to help you with that particular compound. So if you can limit to not trying to compound in your office and using your local compounding pharmacy, or your pharmacist can direct you the right way, then that will again save you a lot of risk factors when it comes to the laws that govern us with compounding. So yeah, this kind of brings us to our end. Here's a slide. It's got some continuing education resources for you guys. Definitely have the state medical board laws and regulatory services that are specific to your state. You have the USB guidelines as we had reviewed. You have the ivnutritionaltherapy.com website to go over any of those things. They do have courses and training platforms. And then again, you have Vita Infusions ATL, which is us and our education platform. And I thank every one of you for attending this webinar, and we look forward to our future webinars together. And thank you very much.
I hope that you got some great takeaway information and learned something new that you can put into your practice today. The Innovation Institute was designed to provide you with the tools and education that you need to help grow your practice and increase your knowledge base. If you enjoyed this lecture, I invite you to continue learning by signing up for the next webinar in our online series. To do so, please visit our website at www.innovationcompounding.com. As always, the pharmacy team at Innovation is here to answer your questions and listen to your feedback. So please reach out to us at any time. Again, thank you for listening and be well.